Hello, my name's Edward Halpern, and welcome back to the New York Medical College Touro University System series of COVID-19 webinars. This is webinar number 20, and I'll be your host. I am the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of Touro University. Our program for today is snatched from your questions and comments from our previous webinars. We're going to have some folks who you've met before in earlier webinars and some people you haven't met. There have been so many questions about the effect of the virus and the effect of the vaccine on the hearing and visual apparati that we're going to have our first two speakers on the eyes and on the ears. We have Dr. Mahesh from the Ophthalmology Department of Westchester Medical Center in New York Medical College, who's going to teach us about how COVID-19 infection affects the eye and the possible effects of the vaccine on the eye. He'll be followed by Dr. Katrina Stidham of the Department of Otorhinolaryngology. She is a specialist in hearing and hearing disorders, and she's going to teach us about how COVID-19 infection and the vaccine affect hearing. We've got yet another new person for you to meet. I've invited Dr. David Rivelli from the Lovelace Biomedical Research Institute of Albuquerque, New Mexico, to join us, because I thought we should talk about monkeypox. What is it? What causes it? How do we manage it? And should we be worried about it? Next up is an all-time favorite of many of you, the Dean of the Touro College of Osteopathic Medicine in Vallejo, California, Dr. Tammy Hendricks, a pediatrician, is here to teach us about what you parents and you grandparents need to know about the evolving data of children getting the vaccine and children getting booster shots. And also, back again, one of our previous speakers, our last speaker today will be Dr. Ronnie Swift, who runs the psychiatry program at Metropolitan Hospital Medical Center in Manhattan and is a professor of psychiatry at New York Medical College. I've invited her to speak with us today about, am I sick and tired of the pandemic, or am I actually depressed? I don't feel like going back to the office. I don't feel like doing things like I used to. What's going on, and how we might recognize the distinction between just having the blues and being depressed among our family members and coworkers, and what we should do about it. As always, if you have a question for any of our panelists, go ahead and type those questions in the Q&A box on your computer screen. We'll be monitoring the questions as the program proceeds, and we'll get to as many of the questions as possible for our panelists at the end of our platform presentations. If you're interested in getting continuing medical education credit, slides will appear periodically in between the speakers, and you'll hear my voice telling you how to get your CME credit. As always, the CME credit is free. And you'll also hear from me intermittently throughout the program, telling you about some course offerings that might interest you in the New York Medical College Touro University system, and also inviting you to help financially support our COVID-19 research and our CME webinars that you're watching today. Welcome back. Thanks for joining us. And let's get started with our program with our first speaker.
My topic today is how does COVID-19 infection affect the eye? I'm Dr. Sankara Mahesh. I'm an assistant professor with New York Medical College. Before we begin, I have no financial disclosures, no conflicts of interest on anything that I speak today. So how does COVID-19 affect the eye? Based on since the first report that came in 2019, which was reported by Dr. Lee, an ophthalmologist in Wuhan, there has been a number of publications detailing the different manifestations of COVID-19. This can be broadly divided into 4 subcategories depending on which part of the eye that is involved. The most commonest is the anterior segment, which involves the eyelid, the ocular surface, and the conjunctiva and cornea. The posterior segment is the which structures involve retina, and vitreous is the other entity that part that can be involved. In addition, visual pathway also can be involved, mainly the optic nerve and the nerves that supply the muscles, which control the eye movements, also can be involved due to COVID-19. And last but not least, the soft tissues around the eyeball can also be involved with inflammation because they are sitting adjacent to the nasal passages and sinuses. How does COVID-19 get access to the eye? This can be due to direct inoculation by the droplets, or it can be migration from the adjacent upper respiratory tract because the sinuses are very adjacent to the orbit. Or this can also come directly from a hematogenous spread, blood spread, once the virus is inside our body. So if you look at the conjunctival swabs, the viral RNA can be seen in around 5% of patients at the high, depending on when you do these studies, even in patients without any ocular manifestations. At this point of time, it is not clear whether the RNA that we isolate from these ocular fluids have any infectious potential or not. In addition, the proteins that the spike proteins in the virus attaches called ACE2 are expressed at a low level in the conjunctival cells and the ocular surface. Up to date, we have not been able to isolate these virus in a culture from these ocular samples, and we have no reason to believe that the virus can replicate in ocular tissues. Coming to the anterior segment manifestation, follicular conjunctivitis, like the common viral pink eye, is one of the commonest manifestations that we see due to COVID-19 virus. It can see in different case series has put this as incidence of around 10%. The median time to presentation is around 8 days, and the conjunctival swab will be positive for up to 5 days at the height of infection. Some studies have suggested that there's a positive hand-to-eye positive hand-eye transmission, while other studies have not shown this as a possibility. The viral pink eye, as we know, is a self-limiting disease, and same thing is the same follicular conjunctivitis due to COVID-19 is also similar. The treatment is usually aimed as symptomatic, hand hygiene, ocular lubrications, and usually this resolves. A late onset keratitis and conjunctivitis is also possible due to immune response triggered by the virus, and usually this responds very well to topical steroids. The photograph on the right side, as you can see, shows the conjunctival inflammation and follicular reaction that we usually see with this kind of inflammation. Coming to, even though we have many cases with the anterior segment manifestation, the posterior segment involvement is limited to some isolated case reports. In the posterior segment manifestation as a result of not direct infection of the virus to the intraocular structure, is more as a result of inflammation or a thrombotic state induced by the COVID-19 itself. The main manifestation that has been reported include a central retinal vein occlusion and central retinal artery occlusion. These are as a result of the inflammatory cascade and the cytokine storm that has been known well with the COVID-19 virus, which activates the clotting mechanism and resulting in vascular occlusions. Central retinal vein occlusion is treated usually with anti-VEGF treatment and usually has a little favorable prognosis depending on how severe the disease process is. On the other hand, central retinal artery occlusions are devastating, and they usually result in poor outcomes because it is a time-sensitive problem, and if you don't institute a treatment within the 90 minutes, the vascular supply is completely lost and results in poorer outcomes. These pictures shows the inflammation of the central retinal inflammation as well as the occlusion of central retinal vein and as well as an artery. Optic nerve involvement and inflammation is less common, but can happen early in the disease process. These patients usually come present with the unilateral vision loss. And on exam, you can see the optic disc edema, hemorrhages, and inflammation around the optic nerve. And the treatment, it's usually thought to be as a result of inflammation from the cytokine storm that is involved, and usually responds well to oral steroids. Other manifestation that has been seen is a tonic dilated pupil or a cerebrovascular accident due to the vascular thrombotic states that I talked about, resulting in vision loss. Finally, the last manifestation that we have seen is involvement of the soft tissues around the eyeball, involving the eye socket or the orbit. Dacryoadenitis is an inflammation of the lacrimal gland. As you can see, the swelling in this photograph is thought to be a result of inflammation secondary and an immunological response secondary to the virus, and usually responds well to oral steroids. Orbital cellulitis, other hand, can be result as because the sinuses are adjacent to the orbit and can cause a contiguous infection or a secondary bacterial infection because of the congestion and the sinusitis that is usually associated with this viral infection. Mucormycosis is a rare opportunistic infection with the fungus and is usually seen in patients with comorbidities such as a compromised immune system, uncontrolled diabetes, use of high steroids, which is usually the use in case of pulmonary complications. These patients are do often poorly, and high suspicion and early diagnosis is very, very important and key for and treatment with antifungal is very important for an optimal outcome. Now, moving on to another topic, how does COVID vaccination and is there any ocular side effects? There are a handful of reports which has been published in the last year since the advent of COVID vaccination, which shows facial nerve palsy, Bell's palsy, or a sixth nerve palsy, or a reactivation of uveitis following vaccination. These reports are isolated and retrospective case series, and a casual association or a causing an established connection is a little bit difficult as there are not many cases. Nevertheless, the symptoms that are described are closely resemble with the reported ocular manifestation of the COVID-19 disease itself. So to conclude my presentation, the ophthalmic manifestations are varied in terms of severity and timing. The anterior segment involvement is directly as a result of infection from the virus to the ocular surface tissues, while on the other hand, the posterior segment and the neuroophthalmic manifestation are as a result of an inflammation in the prothrombotic state induced and triggered by the virus itself. Thank you.
Hello, this is your host, Dr. Edward Halpern, back to tell you how to get your continuing medical education credit. You have three ways you can do it. You can send a text message to 828-295-1144 and type in the activity code 08CHOP, C-H-O-P, all in capitals, 08CHOP. If you do that, you'll get a response back telling you how to do your satisfaction questionnaire for today's program and how to get your CME credit. If you don't like doing text messages, you can go to our website, www.eeds.com, click on the sign in button and follow the procedure. Or finally, you can whip out that electronic device and scan the QR code, and it will take you to the website to put in the activity code and to do the questionnaire and to get your CME credit. Now, all of these options are going to expire on Monday, July 18th at noon. So I suggest you get about your business applying for the CME credit, or at least do a screenshot or take a photograph or write these numbers and activity code down so you can be sure to sign up for your credit and fill out the satisfaction questionnaire. As always, if you have a question for any of our panelists as the program proceeds, type it in the Q&A box on the bottom of your screen. And now let's get back to our program.
Hi, I'm Katrina Stidham, and I'm going to go through a brief overview of sudden sensorineural hearing loss and COVID-19, the impact of infections and vaccinations. I have nothing to disclose. So when COVID-19 hit, there was an initial wave of patients reporting hearing loss after the infection, with some patients having just tinnitus and some people having longer-term hearing loss. And then in the subsequent year, once the vaccinations began, there was also significant chatter among ear subspecialty groups regarding a possible uptake in presentations of sudden hearing loss following vaccination, with some of these patients also having overlapping other symptoms such as dizziness and tinnitus. Just to ground everyone here, what we're talking about with sudden hearing loss, this is something that affects either the inner ear, the cochlea, which is that snail shell on the picture, or the cochlear nerve, which is the yellow nerve coming out of the cochlea. So we're talking about a nerve hearing loss. What do we know about viral infections and sudden hearing loss? First of all, sudden hearing loss has a reported incidence of about 5 to 20 cases per 100,000 people a year. And it's characterized by a rapid onset of sudden sensorineural hearing loss occurring immediately over a course of several hours. And there are several different things in the differential diagnosis for sudden hearing loss, but one of the most common etiologies suspected is a viral etiology. And we know of many viruses that have been associated with sudden hearing loss in the past, and this is just a list of a few of them. There have been multiple studies that have shown no significant benefit of giving antiviral therapy for sudden hearing loss. There is some benefit from early steroid intervention for some, but not all patients who suffer sudden hearing loss following a viral infection. And there are several hypotheses for why viruses can cause a sudden hearing loss. And these are some of the ones that are listed here: direct invasion of the cochlear nerve or the cochlea. You can also have reactivation of a latent virus that stays in the soft tissue, and we see this in Ramsay Hunt. There also can be an indirect triggering of an antibody response. And then kind of the prevailing theory these days is that of a cellular stress response pathway, where the virus, along with other stress factors, causes a stress response in the inner ear with a sudden loss. I'm going to give you a case study here of a patient of mine. This was a 38-year-old who already had hearing loss prior to COVID infection, but she had usable hearing and was wearing hearing aids. She had a quite severe infection, and she was actually 29 weeks pregnant, and they necessitated an emergency C-section, and she was actually intubated for 5 weeks. When she awoke, she noted that she could no longer hear with her hearing aids, and she had in fact progressed to a profound hearing loss. The loss was severe enough that she could no longer wear her hearing aids, and she ultimately had a cochlear implant on the right side. So what data do we have about sudden hearing loss with a viral infection with COVID? There mainly are case reports, but there are a few larger systematic reviews, including one meta-analysis where they included 4 papers. And in that study, they found there was approximately a 3.1% occurrence rate for hearing loss in patients with COVID-19. However, they couldn't really link the severity of the loss with the severity of the infection. And they noted that there really was no control for other possible ototoxic interventions, including some medications such as hydroxychloroquine, which was used early on with the viral infection. A second systematic literature review looked at 28 case reports in series and some cross-sectional studies. And in that study, they found an estimated prevalence of approximately 7.6%. They acknowledge that this may be falsely elevated, and again, note there's a dearth of high-quality studies. The most recent study in 2022, again, looked at studies and case reports. And in this study, they found that most of the studies identified a higher rate of sudden hearing loss after COVID infection, but some did not. Of the ones that did, typically it occurred in adults, was unilateral, and the time of presentation varied from a few days to a few months. The majority of patients did have other symptoms, including vertigo, tinnitus, dizziness. And of note, most patients did not have any abnormalities on imaging, but a few did have intralabyrinthine hemorrhage noted on the MRI scan. Now I'm going to move on and discuss sudden hearing loss after COVID vaccine. And I want to give you a case report again of a patient of mine. This was a 63-year-old patient who had a somewhat complicated otological history with a prior stapes surgery on the left side, a fluctuating and progressive hearing loss on the right side, consistent with an autoimmune inner ear disease. But she had maintained really good hearing on the left side and wore a hearing aid on that ear with no fluctuations on the left side for many years. Following her second COVID vaccine with Pfizer Vaccines 7 days post-vaccination, she did suffer a sudden hearing loss, and her hearing progressed from what you see on the left side, which was a mild to severe loss with an 88% discrimination, now down to a profound loss with an only 12% discrimination. And she now is in a range where she's considering a cochlear implant for that ear. The data for sudden hearing loss following vaccination is actually more sparse than it is for infection. There's one good study from the House Ear Group, and this is a subspecialty otology group in California. that had noted an uptick in the presentation of sudden hearing loss following vaccination. And what they did was look at the annual presentation of patients presenting with sudden hearing loss in their clinic for 3 years over the same 1-month period. So from 2019 to 2021, they looked at the presentation of patients in their population, and they saw a significant increase in 2021 compared to the prior 2 years. They then subsequently looked at 30 patients who had sudden hearing loss and found certain specific characteristics. Most of these were patients around the age of 60 years of age. The mean time from vaccine to symptoms was approximately 10 days. And interestingly, 37% of the patients had prior inner ear disorder diagnosis, such as Meniere's disease or autoimmune disease, but most of these had been stable in prior months and years. They ultimately concluded there was no definite correlations, but they did note an increase in incidence, but still recommended all patients adhere to the CDC recommendations for vaccination. The study that is currently most off-cited and probably has the most comprehensive data is that of Formeister et al., where they looked at the VAERS data in late 2021, as well as a case series from 3 institutions. And with the VAERS data, they made specific assumptions, basically only including patients that had reported audiograms or had seen an ENT doctor, and they assumed that the reports were about 50% underreported. When they looked at the VAERS data, they did find that there were 2,000 patients that had reports of sudden hearing loss, 555 met the inclusion criteria. Overall, the end result was they found COVID vaccination did not result in an overall increase in sudden hearing loss over the prior year's reported incidence of idiopathic sudden hearing loss. When they looked at their case series from 3 institutions, they did actually exclude Meniere's patients, so it's different than the prior study. And when they did that, they again did not find any association between vaccination and sudden hearing loss, although they do concede that there may be a subpopulation of patients such as the Meniere's and autoimmune patients that could not be excluded because they did not evaluate those directly. In conclusion, there are reported cases of sudden hearing loss after COVID infection. The exact mechanism for loss can't be confirmed. There's extreme variability in the case presentations and really a lot of missing clinical data to give us better answers. There also is reported sudden hearing loss after vaccinations. However, the VAERS data thus far does not support that there is an increased incidence over the normal presentation. However, there may be subsets of patients that are not fully evaluated in that data collection, particularly the Meniere's and autoimmune inner ear disease patients. And further prospective investigation really needs to be completed to identify possible association between vaccination and sudden hearing loss in those subset populations. Thank you very much.
Hello again, this is your host, Dr. Edward Halpern, reminding you to please consider giving back to New York Medical College. Today's webinar, like all 20 of our webinars, and our research on COVID-19 require time, effort, and money. I hope you'll consider making a tax-deductible gift to help offset our costs of our research and these CME programs. Great things are happening here at New York Medical College. We hope you'll want to be a part of it. In order to give back to the college for the webinar or to support our research, you can call 914-594-2720 and make your donation that way. You can go online to www.nymc.edu/give and make your donation online, or you can write a good old-fashioned check made out to New York Medical College, put on the memo line, it's for the webinars or for COVID-19 research, and mail it to the Office of Development at New York Medical College, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Remember to type those questions in the question and answer box on your computer screen as our program continues. And we thank you for thinking of us during these challenging times. Stay safe and healthy. And now let's get back to our program.
My name is David Rivelli. I'm an infectious disease research scientist and director of the High Containment Laboratory here at Loveless Biomedical Research Institute in Albuquerque, New Mexico. And I'd like to talk today about monkeypox, what it is, what causes it, how do we treat it, and should we be worried about it? I have no conflict of interest related to this presentation. So monkeypox, what is it? Well, monkeypox is a zoonotic disease or a disease in animals that can be transmitted to humans. Generally, cases of monkeypox are found in tropical Africa and occur when humans come into contact with infected wild animals. Monkeypox is a member in a group of viruses called orthopox viruses that can infect mammals. 4 viruses in this group can infect humans: smallpox, cowpox, vaccinia virus, and monkeypox. The first identified human case occurred in 1970 in an infant in Zaire, what is now the Democratic Republic of Congo. It was initially misidentified as smallpox because of the characteristic lesions, which are very similar visually to smallpox lesions. There are 3 main reasons why the world has seen an increase in the number of monkeypox since 1970. Namely, as smallpox cases declined because of eradication efforts, the underlying cases of monkeypox became apparent. The misidentification was due to the similarities in the disease presentation, such as the lesions. We can see examples of those on the slide in the bottom right-hand corner pictures of the feet. The feet on the left are a patient with monkeypox. The feet on the right is a patient with smallpox lesions, both very similar and hard to differentiate. Number 2, the smallpox vaccine protects against monkeypox, and cessation of the global eradication drive left younger unvaccinated generations and those vaccinated individuals with waning immunity vulnerable now to monkeypox. And 3, we just got better at identifying and had better surveillance. So transmission, the natural host of monkeypox is still unknown. Humans are only accidental hosts. Some hypothesize the natural host to be a rodent, something like a squirrel. Whatever the case, monkeypox can be transmitted to a number of mammals and then to man. Direct or indirect contact with live or dead animals is assumed to be the main route of transmission to humans from infectious material containing lesions or bodily fluids. So I want you to think about bites and scratches, aerosols, potentially respiratory aerosols from animals, mucous membrane contact, so think eyes, nose, mouth, and also ingestion and preparation of contaminated flesh. Although not efficiently, humans can transmit monkeypox to other humans through direct or indirect contact with infectious material from lesions, bodily fluids, contaminated surfaces, even contaminated clothing. The virus enters the body through broken skin or mucous membranes. Think again of cuts, wounds, contact with the eyes, nose, mouth, and respiratory aerosols. So the disease. Well, after exposure, the incubation period can last up to 2 weeks. The time between initial symptoms and disease and the lesion development can last between 1 and 3 days, and infected individuals can experience fever, back pain, muscle pain, fatigue, and swollen lymph nodes. The lesions then develop, and we have some examples of those on the right-hand side, and they develop simultaneously all over the body, concentrating primarily on the extremities. And so I want you to think about arms, hand, feet, and legs. And the disease itself resolves within about 2 to 4 weeks. So diagnosis and treatment. Initial diagnosis of monkeypox is based on patient history, where the patient lives or has traveled to, and the presence of lesion and swollen lymph nodes. In fact, lymphadenopathy or swollen lymph glands is common and is the major clinical difference between smallpox and monkeypox. Definitive diagnosis comes through the PCR assay. There are really no specific treatments for monkeypox. Orthopox viruses are similar enough that treatments that are developed or have been developed for smallpox also work against monkeypox. And so we have a number of antivirals, Tembexa, T-Pox, Vestid, and of course, intravenous vaccinia immunoglobulin. We also have 2 vaccines. We have the older vaccine, which is the ACAM 2000, which is a live replicating vaccinia virus vaccine, and the newer vaccine, Jynneos, which is a live non-replicating vaccinia virus vaccine, which has been used for the current outbreak. So the current outbreak, unlike previous outbreaks, which normally occur in tropical Africa, the current outbreak is mainly occurring in Western countries of Europe, in North and South American countries, Asian countries, as well as Australia, as well as Africa. As of the 5th of July, there were over 7,000 global confirmed cases, with 559 confirmed cases in the United States. The majority of these cases, however, are found in Western Europe and the UK. This outbreak is not typical. Most cases, in fact, the vast majority of cases, are in men who identify as gay, bisexual, or as men who have sex with other men. In the UK, nearly half of infected men polled in a recent survey confirmed that they had traveled internationally, which probably explains the rapid global spread. But I do want to clarify one thing. This is not classified as a sexually transmitted disease, but is probably linked to the intimate contact with infected material, bodily fluids, through sex acts. So should I be worried about it? Why not? Well, it's hard to say at this point because cases are still rising, but probably not in the long term because, like we discussed before, the world already has vaccines and antivirals that we know work against monkeypox. Some of those have been stockpiled. Continued outbreaks of the disease in tropical African nations is due to close contact with infected wild animals. This is not true for countries outside of Africa. There are no known natural hosts outside of Africa. Close contact between animals and humans is required for repeated human outbreaks. And monkeypox is not transferred from human to human very efficiently. So long chains of human-to-human transmission are not likely to occur, which are needed to sustain the disease in a human population. This means that these local outbreaks are probably going to be self-limiting. I'd like to thank you today for the opportunity that I had to give this presentation.
Hello, this is your host, Dr. Edward Halpern, reminding you that if you are interested in the public health or the medical ethics aspects of the pandemic, and you or a family member might be interested in taking a course in these disciplines or considering getting a master's degree or a certificate of competency, we'd be happy to hear from you. For our public health course offerings, nymc.edu/COVIDPH for public health, and for medical ethics, nymc.edu/COVIDethics. Use either of these websites to learn more about our course offerings, certificate programs, or master's or doctoral degrees in these areas. As always, if you have any questions for our panelists, type them in the Q&A box, and let's get back to our program.
Hello, my name is Dr. Tammy Hendricks, and I'm a professor of pediatrics and the Dean and Chief Academic Officer of Touro University, California, College of Osteopathic Medicine. Today, I'll be talking to you about updates regarding COVID-19 vaccinations for children. I have nothing to disclose for this presentation. I'm going to start by addressing some of the controversy around COVID-19 vaccines for kids. Here we can see the tweets of a famous senator who's questioning the validity and necessity of the vaccinations. I want to point out that panels of experts in multiple scientific and medical groups have thoroughly reviewed the data and strongly concur that COVID-19 vaccines for kids are safe and necessary. This includes the CDC, the FDA, the American Medical Association came out with a strong statement of it is imperative that all parents in all jurisdictions have access to the vaccine for infants and children, and we're hopeful that millions more children will receive the vaccine in the coming weeks and months, reducing their risk of COVID-19 infection, hospitalizations, and death. The American Academy of Pediatrics also came out with a very strong statement, as have multiple hospital groups. Here we look at the weekly hospitalization rates of patients with COVID-19. This represents the national state aggregated reports from healthdata.gov. Here we can see that the hospitalizations had its highest peak in January of this year. Since April, we've seen a slow but steady increase of pediatric COVID hospitalizations. The American Academy of Pediatrics gives us their weekly report. Following this report closely, we can see that over the last few months, there's been a consistent and steady increase in the number of cases. There have been 13.8 million cases of pediatric COVID-19 in the US since the pandemic started. This represents 19% of the total of all COVID-19 cases. Just in the past week, there's been about 76,000 cases of pediatric COVID-19. This represents a 1% increase over the past 2 weeks. The total number of hospitalizations of pediatric patients due to COVID-19 remains low, 0.1 to 1.5%, as do the total number of deaths due to COVID-19, 0.01%. However, those percentages are low, but if we're talking about 76,000 cases a week or 13.8 million cases in total, it is not an insignificant number of pediatric patients who are hospitalized and who die from COVID-19. This chart is focused on the number of children who have died from COVID-19 since the pandemic started. The total number as of July 6th was 1,260. We know that kids can have mild and asymptomatic infections due to COVID-19. Even with those asymptomatic and mild infections, they can spread it, and we are certainly seeing widespread COVID-19 right now across the United States. As we just talked about, kids can also get severe and acute COVID-19. They can be hospitalized, they can die from it. Multisystem inflammatory syndrome in children, or MIS-C, continues to be a risk that kids face. We've had over 8,500 documented cases of that here in the US. Children are also susceptible to developing long COVID, that post-acute sequelae of SARS-CoV-2 infection. Long COVID symptoms in kids can include problems with their hearts, their lungs, chronic fatigue, and mental acuity. We know that the current variants in circulation are pretty good at evading our immune system, which means we're seeing vaccinated individuals testing positive for COVID. What we're continuing to see, though, is that vaccinations protect people from those bad outcomes, hospitalizations, and death. This is true for the pediatric vaccinations as well. Let's take a quick look at what is currently available in the US. So these are the Pfizer vaccines that are available for pediatric patients. Here we can see the dosages increase from 3 micrograms for those individuals aged 6 months to 4 years, up to 10 micrograms, up to 30 micrograms. I've included in this chart the date at which they were approved for their emergency use authorization. For the Pfizer vaccines, typically for 5 to 11 and 12 and up, there's 2 doses, 21 days apart. For the younger crowd, 6 months to 4 years, there are 3 doses. The first 2 are 21 days apart, and then there's an additional dose 8 weeks later. I'm adding into this chart the Moderna vaccines that were just recently approved for the pediatric populations. Those are all 2 doses, 28 days apart, but we can see, similar to the Pfizer vaccines, the dose strength changes depending on the age of the child. So from 25 micrograms for 6 months to 5 years to 50 micrograms up to 100 micrograms. For Pfizer, there have been boosters that have been approved, not yet for 6 months to 4 years, although that is a 3-dose series, which represents 1 more dose than what they do for all their other ages. For 5 to 11 years, boosters recommended 5 months after the second dose. Same with 12 to 17 years, same with 18 years and up. And for adults, special populations, a second booster is now recommended 4 weeks after your first booster. Right now in the United States, there's a Moderna booster that is approved for adults only, no Moderna boosters for the pediatric populations. So let's talk about some of those special circumstances. Which vaccine should my child receive, the Pfizer or the Moderna? Whichever vaccine is readily available. Right now, because there is such widespread COVID, a lot of children have come down with COVID already. So when can your child be vaccinated after they've had a COVID infection? You certainly want to wait until after their isolation period is complete. We want to make sure that they are staying isolated and not spreading the infection. There have been some experts that recommend waiting up to 3 months post-infection. So allowing the body's natural immunity to help protect the individual, as well as allowing for a little bit of a different response to the vaccine when you receive it. We do know that vaccination induces a much higher antibody response than natural infection. So we strongly recommend that individuals who have had COVID-19 still get vaccinated. Age at the time of the vaccine. Let's say that you have a 4-year-old child who is about to turn 5. They may get a smaller dose if they're 4 years at the time of their first dose, and then get the larger dose if they're 5 years at the time of their second dose. And that is absolutely fine, still safe and effective. They receive the vaccine dosage and formulation based on their age on the day of vaccination for each dose. Timing with other vaccinations. According to the CDC, COVID-19 vaccines and other vaccines may be given at the same time. There is no need to wait or stagger the different vaccines. History of allergic reactions. People who have had allergic reactions to other vaccines can still receive the Pfizer and Moderna vaccines, as long as they have not had an anaphylactic response to a component of those vaccinations. So in quick summary, yes, children should be vaccinated against COVID-19. Right now, we have Moderna and Pfizer options available down to 6 months of age, with boosters available for everyone older than 5 years. Thank you so very much.
Hello, this is your host, Dr. Edward Halpern, back to tell you how to get your continuing medical education credit. You have 3 ways you can do it. You can send a text message to 828-295-1144 and type in the activity code 08CHOP, C-H-O-P, all in capitals, 08CHOP. If you do that, you'll get a response back telling you how to do your satisfaction questionnaire for today's program and how to get your CME credit. If you don't like doing text messages, you can go to our website, www.eeds.com, click on the sign in button and follow the procedure. Or finally, you can whip out that electronic device and scan the QR code, and it will take you to the website to put in the activity code and to do the questionnaire and to get your CME credit. Now, all of these options are going to expire on Monday, July 18th at noon. So I suggest you get about your business applying for the CME credit, or at least do a screenshot or take a photograph or write these numbers and activity code down so you can be sure to sign up for your credit and fill out the satisfaction questionnaire. As always, if you have a question for any of our panelists as the program proceeds, type it in the Q&A box on the bottom of your screen. And now let's get back to our program.
I'm Dr. Ronnie Gorman-Swift, and I'm going to speak on, is it COVID blues or depression? I have no disclosures to report. What are the blues? They're considered to be a form of situational depression. And situational depression is a form of depression that can be triggered by certain events, such as the death of a loved one, a car accident, troubles at work or school, experiencing a crime, experiencing natural disaster, losing a job, divorce, relationship issues, having a baby, retirement, moving, family problems, experience a global pandemic. Situational depression can occur within 3 months of experiencing a triggering event. It occurs when an individual is unable to cope with a new major life change. It can improve over time after the event has happened or after enough time has passed since the event. However, situational depression can worsen over time and eventually become clinical depression. This can happen if it's not addressed or if the triggering event lasts for a longer duration. The signs and symptoms of COVID blues include feelings of sadness, loneliness, emptiness and hopelessness, restlessness, guilt, anger or irritability, more than somebody normally experiences, withdrawing from things typically enjoyed, constant fear or worry, trouble with focusing, increasing or decreasing appetite or weight, avoiding friends or family, sleep disturbances, sleeping too much, too little, frequent crying, thoughts of self-harm, trouble carrying out daily tasks, and feeling overwhelmed with stress and anxiety. Some ways to cope are establish a standard sleep routine, exercise, eat well, spend some time outdoors, disconnect from social media, meditation, find new hobbies, connecting with friends and family, avoid media surrounding COVID-19, especially negative media, positivity rates and death rates. Set goals, seek help from a mental health professional if you need it, and make sure you do self-care. Clinical depression shares many of its symptoms with situational depression. However, the key difference between the two is duration. Clinical depression lasts longer than situational depression. Individuals with clinical depression may find that they feel down or depressed for most days for a longer period of time. This can interfere with their ability to work, sleep, eat, and take interest in activities that they used to enjoy. Situational depression is said to come and go in waves, whereas a depressive episode can last at least 2 weeks. These episodes may include moments of happiness or joy, but they're really overshadowed by feelings of anxiety, sadness, or anger. Clinical depression can also lead to suicidal ideation, and in severe cases, suicide attempts. Cognitive symptoms of depression: worry, ruminating thoughts, worthlessness, low self-esteem, guilt, distortions, misperceptions, difficulty concentrating, increased distractibility and spaciness, and decreased attention and focus. Depression in children. 1 in 9 children ages 5 to 15 have been diagnosed with a mental health condition, which means more than 3 children in every classroom. Behavioral disorders are 5%, emotional disorders are 4.1%, and those are the most common ones in 5 to 10-year-olds. Between 2004 and 2017, there was an increase of 3.9 to 5.8 in emotional disorders like anxiety and depression. Half of a lifetime mental health problems begin by age 14. 75% of mental illness are thought to start by the age of 25, and 70% of children who experience mental health conditions do not have an appropriate intervention at a sufficiently early age. So what is the incidence? 1% in preschoolers, 2% in school age, 5% in adolescents, and lifetime prevalence during adolescence parallels adult lifetime prevalence, which is close to 20% in some studies. Infants and toddlers, this is how it might manifest: sleep disturbance, sad or flat facial expression, little motor activity, failure to grow and thrive. Preschoolers, dulled, flat affect, frequent, unexplained stomach aches, headaches, fatigue, overactivity, or excessive restlessness. The symptoms of depression in children and adolescents: frequent and unexplained physical complaints, changes in sleep pattern, drop in grades, low self-esteem, excessive worrying, morbid or passive suicidal thoughts, mood, irritability, feelings of sadness or hopelessness, boredom, and I don't care attitude. Kids who have a bad attitude, or that's what it's thought to be. Social isolation. Effects of depression on children: distorted thinking. The depressed child's view is changed, different and distorted from your view. The child is not aware of being depressed or aware of the changes to his or her thinking. Don't assume that the child knows and understands their own depression. They have inhibited communication. They lack the words to describe their feelings and internal experiences. This leads to further feelings of confusion and isolation. Don't rely on the depressed child to tell you what they need or feel. Warning signs of suicide. The behaviors listed below may be some of the signs that someone is thinking about suicide, talking about wanting to die, great guilt or shame, being a burden to others, feeling empty, hopeless, trapped, or having no reason to live, extremely sad, more anxious, agitated, or full of rage, unbearable emotional or physical pain. Changing behaviors such as making a plan or researching ways to die, withdrawing from friends, giving away important things, making a will, taking dangerous risks such as driving extremely fast, displaying extreme mood swings, eating or sleeping more or less, or using drugs or alcohol more often. There are national prevention suicide hotlines, and after July 16th, just dialing 988 will get you to a suicide hotline, or you can text 741741. Thank you.
Well, I want to thank all of our panelists for a very stimulating set of presentations. This is your host again, Dr. Edward Halpern, and now it's time for the question and answer portion of our program. We have an awful lot of questions, as we always seem to do for these webinars. But first, in the interest of full disclosure, I'm sorry to report that Dr. Hendricks finds herself someplace in the United States where she can't get a good internet signal, so we're not going to be able to bring her on live for answering questions, but all our other panelists are here. So let me ask both Dr. Stidham and Dr. Mahesh to come on with their videos and unmute themselves, please. We've got a question for both of you. The questioner says, in an earlier webinar, Dr. Mille Etienne, a neurologist, taught us about loss of smell from COVID infection and explained that he thought that the virus entered the nose and then invaded directly into the olfactory nerve. And that's why people lose smell. Does the same thing happen, the questioner asks, with the nerves for vision and the nerves for hearing? So why don't we do this in alphabetical order? Dr. Mahesh first, Dr. Stidham next.
So that's a good question. That's an excellent question. Yes, the virus has been known to invade the olfactory nerves and it can reach the neural pathways. But the vision loss most likely that happening we see with COVID-19 is not directly related to an infectious process. It's most likely because of an inflammation the virus triggers, and the inflammation is what is affecting the visual pathways, causing inflammation of the optic nerve or one of the other nerves that control the eye muscles. So in short, it is not a direct effect of virus invading. It is the after effects of the inflammation that is triggered by the virus itself, which leads to a secondary loss of vision.
Thank you. Dr. Stidham?
So we don't know exactly, and with sudden hearing loss, in one of my slides I had mentioned there's several different theories for why it can happen, and one of them could include direct invasion of the cochlear nerve, although that's thought to be less likely the cause. Probably the more likely cause is a cellular stress response pathway that gets activated, and it's kind of a complex cascade pathway where the infection, along with other physical stressors, psychological stressors, including perhaps some already pre-existing dysfunction of the inner ear, causes this cascade pathway that then damages the inner ear.
Well, Dr. Stidham, let's do a follow-up on what you just said, because we heard in our first couple of webinars when the pandemic started all about the inflammatory cascade in the lungs. People end up on ventilators. People have disseminated intravascular coagulation. So one of our questions in the list is, so if it's an inflammatory cascade, how come people don't always lose hearing bilaterally? Why is it often unilateral? If it's a systemic process, why isn't it a systemic injury?
Yeah, it's a good question. And we know we've had viral sudden hearing loss, obviously, for many years before we had COVID. And rarely it will affect both ears, but most of the time it's actually one ear that seems to be the target where there's a severe loss. And if you go back to that cellular stress response pathway, it actually kind of fits perfectly with that, because there can be different factors impacting one inner ear compared to the other. So for example, a lot of people have mildly asymmetric hearing loss where they may have had some kind of trauma to their inner ear or maybe their middle ear. And it could just be that little bit of difference in the function of that ear sets that ear up for that stress response pathway more than the other. So that's the best theory. Again, there's some other theories about how the virus itself can actually be kind of latent in the cochlea and get reactivated. And so, for example, like Ramsay-Hunt is a reactivated virus for varicella. So possibly that could be another way that it behaves, but it seems that the cellular stress response pathway explains it the best.
Thank you. Well, we've got one more question for the both of you while I have you both here. This question is, in the earlier webinars before the vaccine, we heard all about pre-existing conditions that set people up for bad pulmonary symptoms. Looked like the disease was worse in people with diabetes or hypertension than the average person. Are there pre-existing conditions which set people up to be more likely to have either visual problems or hearing problems from COVID-19? So let's do the reverse of alphabetical order on this one. Dr. Stidham first, and then Dr. Mahesh.
So that is a point of contention right now. If you look at the overall VAERS data, the answer is it doesn't seem like there's an increased incidence. If you ask otologists, there does seem to be some subset populations that are at higher risk. And I think the problem is because we see sudden hearing loss all the time anyway, it's hard to know. I mean, these are mainly anecdotal reports, but people who have, for example, Meniere's disease or autoimmune inner ear disease, there is, as you saw in that one study, it seems to be a higher incidence of these sudden reported losses in that subset population. And I think many otologists, myself included, have seen patients who have those diagnoses that we seem to be seeing a higher risk of sudden loss than other patients. But there's just not enough data to tell us for sure.
Dr. Mahesh.
At least there are at least review of literature right now. If you look at, there is no evidence to suggest that this pre-existing ocular diseases has any role in having a worse outcome or predisposes to a bad outcome from COVID-19. But having said that, as I mentioned in my last slide of my talk, if people with bad diabetes or who have coexisting conditions of severe pulmonary infections, they are more prone for developing the fungal infection that I talked about, mucormycosis, which we saw quite a number of cases back in India where people were initially getting treated with high dose of steroids for pulmonary complications. So these patients had been predisposed to mucormycosis. So that's the only thing that I can think about as far as eye is concerned, but none of the other ocular manifestations have any relation with any pre-existing ocular diseases.
Yeah, thank you, Dr. Mahesh and Dr. Stidham. I'll let you both take a break for a while because looks like we need to talk about monkeypox. Dr. Rivelli, you're on. You got people worried about a couple of things. Dr. Rivelli said that monkeypox could be transmitted through contaminated clothing. Now I got something else to worry about. Do I have to wash my clothes in a specific way to minimize the risk? Do you have any wash day advice for our concerned listener?
Oh, I think that's a really good question, and definitely, you know, people are concerned about these, and really the answer is no. The soap and detergent in your will inactivate a number of viruses. I think it's important to realize, though, you know, again, we ask the question: should we be worried about monkeypox? And I think you know, at this point, I'm not worried. I use my Tide and wash my clothes. and just fine. I think it's important to note where you're at, and do you know somebody who, or have had close contact with somebody who has a confirmed case of monkeypox? And when you're considering, should I be worried about washing my clothing? But I think at the end of the day, washing your clothing with regular laundry detergent is going to be just fine. If you have any other questions, about have I been around somebody or something, your primary care physician will be a treasure trove of information for you. Thank you. That's a good question.
Well, stay with us, because I've been hosting these webinars now for 3 years, and I know someone's about to type in, wait a minute, should I worry about going to the laundromat?
No, again, these are all, these are all questions that kind of pop up in our heads. We saw that with COVID-19. We saw it before that with influenza. Again, I think the recent pandemic has taught us some really good things. And no, I don't think you should be worried about it. But again, we should practice good hygiene. We should wash our hands. We should use hand sanitizer. We should be aware of where we're at and what we're doing. And if we're asked to social distance, then we should do that. But again, this is a new outbreak that we're learning more about. And as we learn more about, our ability to help each other out and avoid infection is going to grow also. And so those are genuine concerns and definitely appreciated. But again, use good hygiene. Wash your hands with soap. Use hand sanitizer. Cover your mouth when you sneeze if you're not wearing a mask. And so those are the things that protect us against multiple types of infections and not just monkeypox or SARS-CoV-2.
Well, stay with me for one more. One of our viewers this afternoon wants to know if she should be worried about getting monkeypox from a household pet. She got to look differently at her dog or a cat because of this, and any other zoonoses that they got to start worrying about now.
Absolutely. And there's a number of zoonoses. So, and I looked at that in the question and answer questions. And again, another question that is a practical life question. How do we deal with this? And the short answer is that there have been no cases of monkeypox in dogs or cats that have been identified. And so the feeling is, again, that you're safe with a dog or a cat. I think the other thing to think about is also here in the United States, unlike Africa, where there's a natural host that harbors this virus, we don't have that. We don't have a natural host, whether it be a rodent or anything else like that, that continually harbors this virus so that it can potentially get out into a human population. We just don't have that. And so there's not the worry here in the United States that this virus can leap from the natural host or unnatural host to our animals and then to us. So we don't have that worry. And so again, I'm not concerned with it. And until we have a little bit more research, again, we're kind of right at the beginning of this, and we need more information. But no, cats and dogs are safe.
Yeah, thank you. We'll let you take a break for a little while because we got some serious controversy for Dr. Swift. Ronnie, can I ask you to come on video and turn your microphone on? Ronnie, you just disappeared. Can you there you go, and turn your microphone on. It looks like you're. Ronnie, we've got a question for you, which is both very modern and very old. The questioner wants to know, do you think a contributing factor to childhood depression anxiety is that they're home playing violent video games. And the reason I say it's both a new and an old question is I'm old enough to remember it's terrible. The kids are watching the Roadrunner and Wile E. Coyote falls off a cliff and goes kaboom, but then he's there in the next scene, or Elmer Fudd opens fire on Bugs Bunny and blasts them with a shotgun, but nothing seems to happen. So look what we're doing to our children. They think violence is okay. And I guess we're re-asking the question now in terms of video games. And I think there's even been some conversation among some legislators about trying to ban certain types of video games or put warnings on it. I know this is a delicate and controversial topic, but can I ask you to tackle that on behalf of our question?
Sure. This is a very, very controversial topic. And as we know, what works for one person, it may be affecting some people who are genetically different than other people. Not everybody's going to have the same response to a violent video game. And so if we see, for example, I've had parents say to me, you know, every time my kid watches that video, what happens is they go beat up their sibling. Well, you have to look at the data. You have to look at the data within your own family, within your own system. And certainly we don't know that there's no clear evidence that it does or does not increase violence, but certainly excessively and looking at the information for a specific child in a specific circumstance. And many parents are very sensitive to this now, that more video games with violence, more TV shows with violence, things like that, and they'll limit their children's ability to use video and to watch things that they see as being more violent. So it's a question to which there is no really good answer, but you have to be a good observer of the child and how it's affecting a particular individual. I hope that's helpful.
Thank you, Ronnie. I have another cry for help here, Ronnie, for you. What's a parent or grandparent to do? The children have been out of school, then they're back in school, then they're worried about getting COVID, then they're worried they're going to have to get a vaccine that's going to hurt. Then they have to worry about whether there's going to be a shooter in the elementary school and they're making my kid hide under the desk because they're rehearsing for that. Then they're worried they can't even go to the 4th of July parade without someone shooting at them. What in the world am I supposed to tell my children or grandchildren nowadays to try to comfort them in a world that seems to have gone mad?
I think you have to be very practical about some of this. We do unfortunately need to teach our children about some of these things. We wish we didn't, but it is in fact a reality. And at all ages, when I was a child, we were hiding under desks because of the fear of a nuclear attack and things like that. So it's at every stage we see this, and we just have to provide an education, but say that life is safe. You know, in general, people are not out to hurt your children or you or anyone else. Do we all worry about it? Of course we do to some extent, but when it begins to paralyze either the child or the parent or grandparent, then it becomes pathological. And what we're teaching the children is that the world is not a place where you can enjoy yourself, where you can take part in fun things. One has to moderate it. And we actually saw at post 9/11, we actually saw children who developed PTSD who were nowhere near the site, but their children, the parents had the TV on continuously, and their children saw the same horrible pictures of people jumping out of a window over and over and over again. And they actually had PTSD from that. So we also have to be sensitive, as I said in my talk, the whole issue of what traumatizes someone. What traumatizes you may not be something that traumatizes me. What makes me really upset may be different than someone else. And particularly what we worry about is people who are predisposed to depressive episodes and predisposed to perhaps suicide. There are families in which there are multiple generations of suicide, and that family has to watch for different things than a family that doesn't have that. And so it's very individual, and we just have to use good judgment and good common sense around these. And when you start finding that that's all you're thinking about, you may have crossed that line from situational depression to clinical depression, and you may need to get some real professional help. And there's no really good guidelines. You have to be able to see that in your own self or in your family members, because it's not so clear cut. But when that's all you're thinking about is what could happen, oh, the child's going out and is going to walk to school by themselves, well, somebody might get them when they do that, then it has crossed the line and it becomes your only way of thinking. And that's not healthy. That's when you need help. I hope that's helpful.
Thank you, Ronnie. Of course, for those of you listening to today's webinar, I also remember hiding under the desk, but I am much older than Dr. Swift. And if you think that the world has gone mad today, I'm old enough to remember from elementary school, they gave us forms to take home to our parents to fill out. In the event of an intercontinental ballistic missile attack by the Soviet Union on Somerville, New Jersey, do you want Eddie sent home or kept in school? So my mother, I remember, filled out the form and said, send them home. You know, do you imagine kids be carrying around forms like that also? So I guess it's a new problem and also an old problem. Thank you, Ronnie. We'll let you have a break for a while. We've got a couple of questions for Dr. Stidham. If I can ask her to turn on her video and unmute herself. The question is, can there be a time lag for hearing loss from viral infection with COVID or from the vaccine? Our questioner specifically wants to know, could you have hearing loss up to a year after the infection with COVID or the vaccine that was related to those events?
So maybe.
That was a long sigh, doctor, before you answered the question.
I would say that maybe more after the infection, and only based on, again, what we know about, historically viral reactivation for other etiologies, right? So we know that we've seen viral reactivation in patients who've had chickenpox and herpes simplex, where the virus lies latent in the nerve and then gets reactivated months or years later. And usually there's some kind of stimulating event that causes that chink in the immune system that the virus is caused to be reactivated. So we have many instances where that's been reported, and we think that some of our sudden hearing loss historically has been viral reactivation in a virus that someone's been carrying for years. So I do think that in that case, if this particular virus acts in the same way as some of the other viruses that we know about, then yes, it could. We would be hard pressed to kind of have a good explanation for why after vaccination you'd have a shift that long after, because we think with the vaccination, if it happens at all, again, it's someone maybe that already is predisposed, and probably it is that immune cascade or cellular stress response pathway, which wouldn't happen a year later. It would be within a certain time frame, and the thought being usually within a few weeks. So, but the virus may be, we don't know for sure whether those sudden losses are a year later are due to the virus, or that's just another cause of sudden hearing loss, perhaps another virus.
Okay. Thank you. Well, we got a classic question from our tough, shrewd New York Medical College Touro webinar audience. Dr. Stidham, you showed a meta-analysis of the risk of sudden sense neuronal hearing loss with the vaccine, and it seemed to show no association. What happens if you do a subset analysis of Pfizer versus Moderna versus J&J?
So I didn't have enough time or space to present all of that. They did actually look at the individual vaccine companies, and they did not see any difference between the vaccine companies. So J&J, there have obviously not been as many of those. So I think the numbers were quite a bit smaller, but there was a significant number for both Pfizer and Moderna. And there was not a difference in the presentation of sudden hearing loss. Like they basically were kind of neck and neck as far as the percentage of those patients. And actually the House Ear group also did look at that with their smaller numbers, and they didn't see a difference either.
Yeah, before I let you go, I want to probe you a little bit that healthcare group study, because you pointed out that the investigators in the meta-analysis assumed a 50% reporting rate.
Correct.
If you're not getting in the car and going to work and going to meetings, if you're sitting home all day, are you more or less likely to report hearing loss and go do something about it? Do we have any idea about how the pandemic has affected reporting rates of this entity?
Oh boy, I think you may be asking the wrong person. I'm not sure. I mean, I think we all know our behaviors have changed dramatically, with particularly so many people that are not doing things they were before. But I have to be honest, I kind of question that. Is that correct? Are people more likely to report now? Or are they less likely to report? I don't know how. I mean, that I think is a standard error factor that they're using when they look at the VAERS data for a variety of things. But I don't know how you come up with that number. I mean, I think there's a general likelihood that there's a certain percentage of people that just never get to the point where they take it beyond reporting it to their doctor, and did their doctor report it or not. But whether they're actually self-reporting more, I don't know.
In one of our earlier webinars, we had a talk about cancer reporting and looking at baseline rates of getting your mammogram and seeing them drop during the beginning of the pandemic in the United States, but not so much in New Zealand, or getting a biopsy for a rectal mass or feeling a lump. That it did in the United States seem to drop off compared to historical rates and then picked up again. So I guess the answer is for hearing, who knows?
Right. I mean,
Yeah.
again, I certainly saw it for other diagnoses. I had skull-based malignancies that left untreated and undiagnosed for months because people didn't come in to get them checked, right? But
Yeah.
for the sudden hearing loss, people typically do come in for sudden hearing loss. Again, I think part of the question though, does it get beyond the treatment in the office to get reported?
Now, thank you. Let's put Dr. Mahesh in the witness chair for a few questions now. Thank you, Dr. Stidham. Well, we got some questions about your slide where you had a bullet point which says, sometimes the virus can enter the eye from droplets. So we've got two variations on this, your slide. One question wants to know, so does that mean I should wear a face shield because I'm going to have less chance of eye problems than if I only wear a mask? Do I need to wear a mask and a face shield because Dr. Mahesh says it can enter my eye through droplets?
That's a very good question. So at the height of the pandemic, the two modes of transmission was hand and eye contact, and also through droplets. The droplets can get into the eye, and it poses two problems. One, it theoretically, since there are receptors, whether it is infectious, which we have not proved yet, it can directly enter the eye, even though the chances of that is very, very low, because the receptors that attach the viral particles to the eye is expressed in very, very low numbers. So that's one issue. Second is the tears are drained naturally into the nasal passages. So if you get a droplet in your eye, even more likely than it entering inside the eye, it can probably go into the nasal passages and set up a COVID infection of the lung and into the body. So that's more likely. So, and theoretically, yes, wearing a face shield is less likely to, it's more likely to help you in preventing getting a COVID infection. Having said that, again, this is depending on there are other factors of how far ahead the droplet is you are from the person who is giving the droplets, how close you are, and there are multiple factors which can affect how much you are getting in, rather than through the air. So the answer to that question is yes, theoretically it can help you, but it's more likely that you may get a COVID infection of your lung and passages rather than in the eye.
Okay. Well, the related question also for you is, if I wear my contact lenses, will it disrupt the protective barriers of the eye and make me more at risk for a viral infection?
It's very hard to short answer. Theoretically, it can, but in reality, it may not. So contact lens, when you wear, if you wear for a long period of time, it obviously can cause hypoxia or lack of oxygen to the cells. So that can cause the cellular disruptions, the cells that are covering the cornea or the front part of the eye. So any disruption, if the virus is infective, can aid getting the virus into the eye. But we still have not proven the RNAs that we isolate from the ocular fluids, they are infective, or whether the virus can multiply inside the eye, that we have not proven. It is probably, they are, because of the low numbers, that's probably one reason we have not been able to prove it. But that, to answer that question, we don't have that answer yet, because we don't have enough data or information on that.
All right. Thank you. Thank you. We've got an epidemiologist with us who has some questions for Dr. Rivelli. So we'll let Dr. Mahesh take a break and put Dr. Rivelli on the screen. Oh boy, here's a good one for you. I really don't understand the distinction you made between an apparent higher number of monkeypox cases in men who have sex with men, and then you said, quote, "It's not a sexually transmitted disease." If the latter statement's true, then shouldn't the incidence of monkeypox in men who have sex with men be no different than the population baseline incident rate?
So I think that is a really good question, and a very interesting one at that. I think I should clarify though that you know, when sexually transmitted diseases are thought of, is generally because the disease itself can be transmitted in semen or vaginal secretions. And this is right now we don't know enough about monkeypox and how it's and all the ways in which it can be you know, given from one person to another, transmitted from one person to another. And so right now we're unsure. We don't think that, but we're unsure that the virus can be transmitted in semen or vaginal secretions, like what we would consider a classical sexually transmitted disease would be. But having said that, you know, we do know that it is transmitted through close, intimate contact, and that close, intimate contact can definitely and will definitely occur through close, intimate relations, and through sexual acts for sure. And so in that case, it's not classified as a sexually transmitted disease, but it can be, and we think is transmitted through the sexual act or close, intimate contact, and that might also be not only through sexual acts, but also through things like hugging and kissing and prolonged face-to-face interactions. And so in that way, I hope that answers your question.
Thank you. Let's, we have another question for you, asking you to comment on one of Dr. Hendricks' points. The question was, as a viral disease scientist, would you be willing to comment on the concept of adjusting the dose of vaccines as a function of age? The questioner specifically wants to know your thoughts about what they perceive as relatively arbitrary breakpoints, a different dose up to 11 and 12 and older, is how we decide how to do that.
Well, I think you know, those types of decisions are made after lengthy, well-controlled studies, and that encompass a number of endpoints. such as immune activation, stability, things like that. I think with thinking about monkeypox, again, we're just at the beginning, and we're finding out more and more. And as we go further, these types of questions are going to be answered, and so that might be again a possibility with monkeypox. But right now, we just don't know. We have a lot to do, and a lot of research to do.
Thank you. Let's give you a break. We've got some questions for Dr. Swift again, if Ronnie could come on. Ronnie, there are two questions here, but I'm going to ask them to you together since they overlap. What could a person do to try to minimize the risk of someone in their household committing suicide? And related to that, do you have any specific advice about minimizing the risk of firearms injuries at home during the pandemic for self-harm or harm of others?
Yes, I think this is a very, very interesting question. I think if we look at the data, there is a higher incidence of people attempting suicide with guns in the home. And what we also know is that in general, we want to make sure that if somebody does have a gun in the home, what they should do is keep the gun separate from the ammunition. It should be locked up. And another thing that's a corollary to this in terms of suicide within a home, if you talk to, unfortunately, there's a lot of data to suggest that once people attempt suicide, and if they don't complete it, what they will say to you, and I've unfortunately or fortunately talked to a lot of people like this in my training years, they will say, I wish I hadn't done it. The second I pulled the trigger, I was sorry I pulled the trigger, or the second I took the pills. So what you want to do is you want to make sure that you remove access, easy access to killing oneself, guns, unused medications, excessive liquor. These are things that are all really, really important in terms of safety in the home. And not having, we assume also that people know what will kill them. That's not true. People do not realize that if you swallow a whole bottle of certain over-the-counter medications, that will kill you potentially. And so it's very, very important that people get rid of things in their medicine cabinets. We've often seen teenagers who will use alcohol in addition to everything they can find in the medicine chest that's left. Why are we saving old pills that we didn't finish taking at the time that they were prescribed? These are questions that we really have to ask, and this is a safety issue. We're all very aware of cleaning products and things like that, but when it comes to something a teenager could impulsively do, or a grown-up could impulsively do, we need to give them time to think through that. And if the means, the gun, the pills, etc., are not there, that makes it a lot more likely that they'll at least think about it for a somewhat longer period of time and not act even more impulsively. Because impulsivity is part of what it is, and people are trying to escape from pain. At that moment, they feel hopeless. They feel like the way they feel at that moment in time is going to be the way they feel for the rest of their lives. And that's also really important to emphasize. And also in families where there've been multi-generational suicides, to really, really be careful in those kinds of families, that those are people who perhaps should not be treated by primary care doctors for their condition. That's somebody who really should see a specialist, a psychiatrist, for their treatment, because I've certainly seen families in which there are 4 generations of suicide. And that's really, really horrifying. And one of those generations was a 7-year-old kid. And you think about, does a 7-year-old even understand what death is? So it's very important, particularly in families like that, to make sure that you remove anything that could potentially be an easy way to attempt suicide. Thank you for that question. That's really important.
Thank you, Dr. Swift. And I want to thank Dr. Rivelli, Dr. Mahesh, Dr. Stidham, and Dr. Hendricks for being our panelists today. I want to thank Ashley McCarrick and Amy Jacobs for the publicity and logistics work. And as always, the wizards of IT, Michael Cotter and Michael Frankfurter, for putting on our webinar broadcast. Thanks for joining us today for our 20th webinar. And as I always seem to say, we'll see you next time, since this doesn't seem to be going away anytime soon. So watch your emails for the announcement of our next webinar, which will be number 21 in about 5 to 6 weeks. Until then, stay safe. Thanks for joining us. And for those of you who want your CME credit, remember that we'll time out by Monday. So go ahead and do it while you think of it. Have a good day, everyone. Bye-bye.